we'd like to move on to talking about other checkpoint inhibitors. So Betsy, would you like to discuss the data with Durvalumab and muscle-invasive bladder cancer and metastatic bladder cancer?
Sure. So there was actually an update presented at this meeting. There was a poster update of the Durvalumab data. And as with all of these, the trials enrolled really quickly. And so as there's more mature follow-up, we're seeing many updates at multiple different settings. So the initial data that was presented at ASCO last year was about 60 patients and showed a really nice response rate in the PD-L1 positive group. This is a subset of over 100 patients, most of which were treated second line. A couple had no prior therapy. What's tricky about the Durvalumab data set is that they amended the enrollment criteria. So first it was all comers, then it was PD-L1 positive, and then it was back to all comers. So I think we have to remember this is a heterogeneous data set and quite possibly enriched for a better group of responders, just given the way that they enrolled. It is given on a 2-week schedule. But one of the most interesting findings at the poster yesterday was that this trial was designed to give treatment for 1 year and then cease. And so they just now have patients who've moved beyond that 1 year. And when they look at the responders, those who made it to 1 year and stopped have all continued to respond. Now, albeit with very short follow-up. So again, one of the interesting things about all of these data sets is since durability is one of the key benefits, that's something that can really only be seen over time. And so we're really only going to know the true benefit 3-5 years from now. But I think the way this study was designed gives us an opportunity for an early look at cessation of therapy. And just a point that Rob touched upon previously is how little can we give? And can we make this really the only treatment patients need for a long time and shorten the duration for both patient benefit, inconvenience, cost, et cetera. So I think those are the things to look for. Again, it's another checkpoint inhibitor. It probably works similarly. The response rate, again, right in that 20% range. Overall survival, right in the 14-month range. We're seeing very much consistent data across the checkpoint inhibitors and very little really to differentiate them in terms of efficacy, in my view.
Well, I think the important point about stopping after a year from this trial is really going to help us. But the problem is we're never going to see a randomized study, which is really the best way to go about this of ceasing treatment or giving treatment intermittently, or because it's going to simply take too long. And we really don't have any intermediate endpoints to look at. Remember, progression-free survival is really fairly short with most of these studies, about 2 to 3 months. So it's forcing us to really rethink our clinical trial designs for this disease. And in fact, with the explosion of all these agents, it concerns me that a lot of these trials may start slowing down in their accrual because we have only a limited number of patients that we can put on study. And so we have to be really, really smart about our trial designs and what we're trying to accomplish, because I believe about 12,000 patients will die from metastatic disease per year, at least within that particular ballpark. It's not as many as patients with metastatic prostate, lung, or breast cancer, but we've got to be very, very prudent about what we're doing, what we're trying to accomplish, and how we're going to try to design
prioritize the important questions in terms of trials.
Exactly. So I think that again, some important data taken from this particular study. So Dr. Quinn, what about CTLA-4? This was one of the first checkpoint approved in melanoma. Ipilimumab, tremelimumab, what are the roles for these agents in the treatment of metastatic bladder cancer?
So the bottom line is we don't know, but we're trying to work it out. We had a very nice study led by the Hoosier Oncology Group that looked at gemcitabine cisplatin with the CTLA-4 inhibitor ipilimumab. It didn't appear like that was going to move us forward. Wasn't a good addition, and we're not going to move forward into a phase 3 study of that one. Where we're seeing both ipilimumab and tremelimumab is in the first line combined with a PD-1 or a PD-L1 inhibitor. So the new trials are going to look at those combinations first line, and the trials that we're seeing, such as the Danube study, the INVIGA 310, and the Keynote 361, are going to be interesting because they'll give us different comparisons. So in the Danube study, at least we've got the combination of tremelimumab and Durvalumab, a PD-L1 inhibitor, that'll give us an idea compared to the PD-L1 inhibitor alone about what the activity is. We also have an ipilimumab versus nivolumab compared to standard of care chemotherapy, either carboplatin or cisplatin based therapy starting. So this is still in development. I would just caution treating oncologists to say, There may be some evidence that CTLA-4 is part of a resistance spectrum or activating spectrum for PD-1 or PD-L1, but this is not, these patients do not have melanoma and they are a very different population. So if you're adding IPI, it needs to be done in a trial, or if you're adding TREMI, it needs to be done in a trial, because there is additional toxicity whenever you add anything. We know that from the melanoma data. And we've seen a number of patients transferred to our inpatient unit with severe toxicity because they've been given melanoma doses of ipilimumab with a combined randomly selected PD-1 or PD-L1 inhibitor, and their average duration when they survive in hospital is 5 weeks. And they do not do well after that. This is an area of active development. We're doing the trials. We need to accrue to them, and until until we have definitive trial data, my advice is not to do it ad hoc at home.
That raises a very, very important point about toxicity and the management of toxicities with immune therapy. I think in general, when you add a CTLA-4 to a PD-1 or a PD-L1, you about double the toxicities, at least from what we've seen from the lung data and the melanoma data. And remember, our patients with bladder cancer generally tend to be a little bit less medically fit. They tend to be older. They tend to have multiple medical problems as well. So I think that we have to also, and this also reflects the importance of developing a marker or a series of markers to tell us who's going to respond to monotherapy, because you don't want to ratchet up your treatment in a person who's frail. And certainly it may not be the right thing to do in that situation. So management of toxicities, I think, is important. And Dean, maybe you can make